Can everyone see that?
Yep.
That is technological joy. Okay, great. So should we go?
Yeah, why don't we get going? People may join later.
Okay. So today is our first journal club in a while. And we are going to talk about this paper here, which is from a Scandinavian Journal of Trauma Resuscitation and Emergency Medicine. And it is a study that's been done in Paris with the title of Performance of Pre-Hospital Evaluations in Ruling Out Invasive Chest Stab Wounds. And those are the authors. So the background reading on the paper talks about the CDC, which is the American Centre, isn't it? And they advocate penetrating chest trauma patients should be managed in sort of tertiary trauma level institutions with cardiothoracic facilities. And then looking at some other countries of how other systems make that same decision. The French are less specific. The French say that unstable patients with penetrating chest trauma should be managed in specialized trauma centers, but they don't specify for stable patients. So it's not a generic decision that all chest trauma, penetrating trauma in France goes to a major trauma center. It's known in background literature that about 15% of penetrating chest trauma patients do require surgery. And there's also a little bit of literature out there of studies that have looked at the ability to identify a hemopneumothorax in stabbing clinically. And those studies have highlighted that clinically we're actually quite poor or quite unable to reliably detect when someone's got a hemopneumothorax without further imaging or investigation.
And what do we say here, Claire? Maybe others can comment as well about
so as
across the UK.
Yeah, so as Mike reliably informs me, this study is particularly pertinent for this organisation because within the M25, the policy, as I'm sure many people are aware, is that penetrating chest trauma goes straight to a major trauma centre. And I guess the MTC network since 2010, 2011 would be our 4 hospitals. Outside the M25, it's more like the French. Unstable patients go to a major trauma centre, but stable patients with evidence of penetrating chest trauma may go to a trauma unit as opposed to a major trauma centre.
Matt, sorry to interrupt. What's the down in KSS's area, CCAM? What's their
so central should go to an MTC,
regardless of physiology?
Yeah, I think it might have changed due to COVID. So I think they think if you think it's a simple pneumothorax, it can go to a TU.
Certainly up in the east of England, and I think other parts of the north, but east of England for sure, their thing is they still haven't added penetrating trauma central stab wounds to their trauma tree. So they go to a TU unless they meet the physiology criteria. Sorry, Claire, didn't mean to interrupt.
Right. Please do. So that's the background of their paper, and also I guess why we find it interesting for us. So looking at the methods of how they put the study together, so it's an observational study, a prospective study that looked at about 3 years of data, and it was a single centre study, which was a large tertiary hospital in Paris. It's based around their PACU, their post-anaesthesia care unit, and their inclusion criteria was essentially all consecutive patients, and they excluded those under the age of 18 and those that were secondary transfers. So their pre-hospital system, their SAMU, that's their pre-hospital doctors. It was a study where they got data from the pre-hospital doctors who would give an opinion on what they thought the wound was based on the location of the wound, other factors, and their physiology. And then that could then be compared with in-hospital data of diagnostics within hospital. And broadly speaking, the study was simply looking at what did the pre-hospital doctors think based on a number of things versus what was the actual answer. to roughly look at how good are we as doctors, or that population of doctors, at clinically detecting penetrating chest wounds. So when the patients came in, every patient, as part of their policy, had a chest x-ray and bloods on admission. The chest x-ray wasn't done if it was sort of a rapid resus transit situation where they were so unstable that they went straight to theatre, but otherwise they did have a chest x-ray done. CT and transthoracic echo wasn't automatic. That was based on a clinical decision, I guess, similar to most hospitals, where it was ordered if the admitting doctor in charge felt it was clinically indicated, but otherwise it wasn't done. So the outcome measures that the study was looking for, the primary outcome measure was looking for the false negative rate of pre-hospital evaluation for the diagnosis of invasive wounds. So I guess essentially looking at how often when we say we don't think there's an invasive wound, are we wrong? And the secondary measure was the rate of the need for emergency surgery or chest drainage in all the patients, and in patients without pre-hospital signs of invasive wounds. So again, I guess, again, as a pre-hospital doctor, when you think, oh, that patient's fine, it was just into the muscle, how many of these patients then go on to actually need a cardiothoracic surgeon or a chest drain, a significant intervention? Because obviously that's also going to be interesting to the appropriateness of what centre they've gone to when you look in retrospect. So the statistics they used a 95% confidence interval for normally distributed variables, which in my limited level of statistics seems to be about consistent with what I see in most things, which is the p-value of 0.05. They used medians and interquartile ranges for other variables, and then most importantly, they looked at the positive and negative predictive values. For categorical variables, it was the chi-squared test or the Fisher's exact test. And for continuous variables, it was the Mann-Whitney U-test or t-test. When the results came back, they had 153 patients in their data series. Unsurprisingly, the majority of which were male, 93% were male, and a bit like the data I guess we see in London, more than half were admitted during the night shift. Of those, 38% had superficial wounds, and 62% had invasive wounds. And they did go on to sort of define different sorts of wounds of what they considered to be superficial and what they considered to be invasive. Essentially, all type invasive wounds could be abdominal or thoracic, and the definition of a superficial wound was no injury beyond the muscle wall, which I guess is consistent with what we would think here. So that table there just shows the final diagnosis for the patients and sort of the matrix, I guess, of what people suspected it would be versus what it actually was. And I appreciate that the French spelling of superficial is a new one. Okay. So that's also the diagram or the picture they gave, and that was how they were defining the areas in which they found the stab wounds, just splitting them into what I guess what we would sort of see as a cardiac area, supraclavicular into the zones of the neck, and then the where they would call thoracoabdominal for when they later define where the wounds were. So quite sort of alarmingly for thinking that we can know what's going on pre-hospital, it turned out to be a 42% false negative pre-hospital evaluation for diagnosis of invasive wounds, a 58% negative predictive value, and a 70% positive predictive value. So with that, I guess we're not horrific at saying when something's invasive, but we're pretty poor at guessing that it's not. Within that patient group from the secondary outcomes, 17% of patients without signs of invasive wound actually needed a cardiothoracic surgeon within 2 hours of admission. And almost half of the patients with signs of invasive wounds went on to have cardiothoracic surgery or at least a chest tube. So looking at the paper and using the CASP form, which is the Critical Appraisal Skills Programme form for cohort studies, we just looked through the various parameters sort of to appraise the paper and the validity of some of it. And so the first few questions go through quite quickly. Question 1, did the study address a clearly focused issue? I thought yes. They'd stated their aims, their outcome measures quite clearly, and that was addressed. Number 2, was the cohort recruited in an acceptable way? Our feeling on that was, although they talk about recruiting every single patient over essentially 3 years, other than the under 18s and the secondary transfers, there's no real clear evidence of how that actually happened, and the odds of them having not missed some patients just seems quite low. I would have thought that had that been done, say, in a UK system, what probably would have happened is the TARN database would have been interrogated to look for the number of patients that had been logged on TARN, and then probably Millennium also would have been interrogated to look at the number of A&E admissions. And then we probably would have then looked at the number of patients we had. And truth be told, the odds are probably as we wouldn't have hit 100%. And it might have been nice to have seen that data. And then maybe there would have been a capture rate of 90% or something along those lines, and then that could have been discussed. But the study just says we recruited everyone, and doesn't really go any further to sort of confirm the percentage or how successful that was. So I've said can't tell.
It's just a question to the group so we get some discussion. So why is it important whether or not they capture every patient? How is that going to, what ramifications could that have?
You'll have a selection and the reporting bias.
Right. So what does, and how does a selection bias, what can you think of a way that might skew or what that might do to the results?
If you've not included a group of patients, either intentionally or unintentionally, then that changes the demographic and changes the cohort of patients that you have recruited.
Mm-hmm. Right, and you can imagine that. Which patients do you think are more likely not to be included? Or is there, do you think, a direction of likelihood for the really sick or the really unsick patients?
I guess it depends. It depends on what. Yeah, it depends whether there's any who the people are that are recruiting and whether or not they've got any biases as to what they want their results to show. Sometimes, if they want their results to show them in a positive light, they might selectively exclude some patients without reporting it, or likewise enroll patients that you can change your threshold for who you enroll and who you don't.
Yeah, so there's always this nefarious kind of, people think that, maybe someone's trying to doctor the results, but that I think is probably often less likely the case. Often more likely it's just that everyone's human, and it's really very, very difficult to do perfect anything in life, particularly research. So whenever you see something that they report like this, where we miss nobody, absolutely nobody, but they actually don't say any way that they did to double check that or confirm that, you can think easily the patient who's really sick, everyone's just so focused on the patient who's really sick, and they don't have time to stop and ask the doctor or the team questions afterwards. Or similarly, the patient that comes in that's such a minor injury, they kind of forget to do the study. So so I think Claire really picked up that point, that when you see something that says, oh yeah, we did it perfectly, usually that's the first you should put a little bit of a red flag up, because almost never is that the case. And then, well, if you did do that, then how can you prove it to us that you did it perfectly? What other mechanisms did you have to screen for patients? And did you have screening logs? Did you have stuff? So when we look at these studies, it's not always to tear them apart. It's to think about, when we're doing studies and stuff down the road, how we can do them better. EHAT is just about to put out a paper that I was involved with before I had left there, looking at their night ops and things, and they in their study, they're going to report that they were trying to get people to collect data every night in the EOC, the paramedics, and they actually managed to collect data on less than half of the nights because people just forgot or whatever other reason and stuff like that. And that's not great, but it's just honest, and that shows a study that they're really interested in doing. So it's you don't have perfect results from things, and you should just be a little suspicious when you see that. So sorry, I'll shut up for a minute, Claire.
No, it's great, thank you. So question 3, was the exposure accurately measured to minimize bias? And for the benefit of everyone else feeling more intelligent than me, I'll freely admit that I didn't quite get what exposure was, and on discussion with Mike for clarification, exposure in this case is essentially the test. So the way I looked at it was, if that question was applied to a COVID antibody test, the COVID antibody test essentially would be the exposure. And what you're looking at was the test done reliably so that you don't get bias. So this was COVID again. Are you testing everybody who's been symptomatic and asymptomatic, and then looking at their antibodies and their antigens, as opposed to maybe just biasing towards one group or another, and the test being done properly? So in this case, the test is the diagnostic test of the pre-hospital physician. So it's essentially asking, was the clinical test looking to see if the wound was invasive accurately measured to minimize bias? And in that respect, my feeling was can't tell. And the reason for that is their pre-hospital team, SAMU, or into English MICA, they say is a mixture, I think, of emergency medicine physicians and some intensivists. It doesn't really describe the number of years of experience of each doctor, and it doesn't really break it up into, say, for example, the data for each doctor. I mean, this wasn't about naming and shaming or celebrating those of us that have got the best diagnostic abilities. But say at HEMS, we're doing trauma every day. Some people have been doing it now for 20 years. Some of us, like me, have been doing it for 3 months. As far as the validity of a test, I kind of thought not really looking at I guess the true clinical background of each doctor making that opinion makes it quite tricky to generalize about the validity or the bias of that as a test. And it doesn't really have any real sort of who or how of the questions that were asked, or how they went about that. I don't know, Mike, if you've got any comments on that, or if you're happy.
Yeah, I was going to say, I don't think anyone here was around when Max Marsden was doing his coagulopathy study. Were you? So
starting it, that adenosine receptor thing.
No, this was his study where he was using a Bayesian model to predict stuff, and I'm trying to remember what he had an interesting name for it.
How much you, on a scale of 1 to 10, he thought you were bleeding. Is that yeah.
So this is kind of like that. You can imagine that this study was probably done like that, where you'd come in, you'd drop your HEMS patient off, you would give your hand over, you're standing around doing your paperwork, some research assistant would come up to you and say, oh, by the way, Matt or Rory or whatever, do you think this guy has invasive wounds, yes or no? What can go wrong with that? What can, in that process, if you don't have that standardized, if that's sort of the exposure asking them, sort of, that's when the tests sort of get, the diagnosis gets declared by them. How can you think of ways that there may be bias introduced into that, or some things that will affect what people say in that response? You're hanging out in Emerge there, waiting, doing your PRF, finishing it off. What usually happens?
You overhear a primary survey.
Quick snap judgment.
Sorry?
You make a much quicker, probably less considered judgment, and you'll make it based on different things each time. If you've not got a set sort of group of parameters that you're looking at, and you're just asked what your thoughts are, your rationale for your decision making might be different every time.
Yeah, so that's true. So I guess if you've asked people just sort of on this out of the blue, they may not have time to really think about it. The converse is true, that if they come into this center all the time and they know that you're doing this study, they may think about it a lot more before you get there. So there may be some difference in changes and stuff like that. The other thing that I was thinking, and Claire had mentioned a primary, but a lot of times you may be sitting there and especially with our sort of trauma team at Royal London, in 5 minutes they could have the primary done in a chest x-ray shot, and it's up on the viewer beside you. And then someone walks up and says, so is that an invasive wound, as you're sort of unconsciously looking out of the corner of your eye and noticing this big black side of the chest or this big, white side of the chest. And you're like, yeah, I think that was an invasive wound, or, and some of these things, if you've ever read Malcolm Gladwell's book, Blink, some of the stuff is entirely unconscious. So you can just by, he has this one study they do where they have someone, they are doing some sort of test, and they include a few words in there, and it's like Florida, gray, and something else in this whole list of word things that they're doing a word matching that seems unrelated. Then they ask them some questions and perceptions about, in a different test a few minutes later, about elderly people. And if they had those words in that test, they have a higher predicted probability of saying negative things about elderly people than if they didn't have those words in the test. So it's really interesting, but they didn't notice that there is those 3 words tucked in this sort of test somewhere, but that influences and biases you. So, very subtle things such as seeing the chest x-ray, hearing what's happening in the primary survey can do that. So if you ask some people the minute they walk in the door, and you ask some people, catch them 20 minutes after they've been emerged, you might get different results because little other bits of information are coming into them. And they didn't really protocolize any of that to try and prevent that at all, which would have been helpful to improve the quality of their study.
Thank you. And then on a similar theme, question 4 was the outcome accurately measured to minimize bias. So that's the outcome as opposed to the exposure. And sort of on discussion, we thought the study probably would have been more robust if every single patient had been scanned. So according to the study protocol, you got a CT scan if it was clinically indicated, and you got a TTE, a transthoracic echo, if it was clinically indicated, but it wasn't like every patient got it. The obvious advantages of that is you don't end up hemorrhaging a whole load of money on the study, and also from an ethics perspective, I suspect exposing people to the radiation of a CT scan when it isn't clinically indicated on normal times, I imagine would have been a lot more tricky, which is probably no doubt why they made that pragmatic decision. But if every single patient isn't protocolized for what investigations they're going to have, you then start looking at sort of the bias. So as say, I don't know, the pre-hospital doctor is Anne Weaver, GD, and they come in and they confidently say, yeah, no, I think it's just in the muscle. And then you've got a TTL who maybe is 3 years post CCT. At the Royal London, everyone gets scanned, but in a system where not everyone gets scanned, are they going to make a slightly different decision if they're on the fence about if that patient gets a CT or not? Are they going to make a slightly different decision about if that patient gets a transthoracic echo? And then you look at sort of the diagnostic, I guess, positive and negative predictive values of those investigations as well, to then actually look at, is the data that you're recording in terms of what the actual wound was as accurate as it could have been if everybody was getting the same study protocol. It also talks about the fact that when the CTs were done, they were read by a radiologist, a surgeon, and I think an intensivist as well. There were 3 people that looked at it. It doesn't really say if all 3 reported it or if it's just the radiologist that reported it. And then I sort of started to wonder also about the sensitivity and specificity of a tiny breach of a pleura with CT, because I've certainly been in plenty of trauma call scenarios where there's much debate about if a knife has breached the pleura or not, but they don't have significant pneumothorax. So I guess you kind of have sort of some borderline data there as well. So for that one, again, we've gone with a can't tell. Question 5, have the authors identified all important confounding factors? And the confounding factors, I guess, were the factors which they acknowledged could have sort of altered data. The study says that their confounding factors were, they appreciate that pain and sympathetic drive will alter sort of observations pre-hospital. So when a doctor's looking at the sort of the clinical numbers, the pain and stress will alter those. we also felt that what they hadn't really discussed was were the radiologists and surgeons blinded to the opinion of the pre-hospital doctors if they thought it was invasive wound. And it goes back to that sort of bias of if the clinical team in hospital haven't been blinded to the opinion of the pre-hospital team, can one affect the other, and then subsequently the next people behave slightly differently as a result. Question 5b, similar, have they taken account of the conflicting founders? That's what I said in terms of them talking about pain and sympathetic drive affecting observations. We felt that the follow-up probably was complete enough, because most things like a pneumothorax or a tamponade or a hemothorax are going to become clinically evident relatively quickly. So actually, it's not like a study where we were missing a 1-week follow-up. The diagnosis would have been made quite quickly. So yes, we thought the follow-up of the subjects was long enough. So looking at the results, so as we looked at before, essentially the positive predictive value sat at 70%. So 70% of the time when we look at a patient and we say, we think that knife has gone through the pleura, it's gone beyond the muscle, we are right 70% of the time. Our negative predictive value is 58%, which I guess is a slightly more worrying bit in terms of thinking about taking someone with a nick on their chest to a trauma unit. And that is when we think it's fine, we're wrong sort of almost 2/3 of the time. And 17% of those patients, 17% of the patients where we didn't think that there's an invasive wound end up with a cardiothoracic surgeon within 2 hours. The results also looked at the sort of a Uden score, which was something that I hadn't come across before. And it's simply a score that I think looks at sort of receiver operating curve numbers, and they sort of gave a range for what they had used. And also in terms of how precise are the results, they'd used a fairly standard confidence interval of 95%. Do I believe the results? Yeah, I think I do believe the results. When you look into their discussion at the end, they look at a number of other studies that have been done. There's not a huge number of them, and they've all reported pretty similar data on not dissimilar populations. And then looking at the results locally, can the results be applied to the local population here? I felt that they probably could. Paris is a big city, London's a big city. They've got a trained physician-led model pre-hospital team, as do we here. And I couldn't see a huge difference in the style of trauma between Paris and London as well. Like if this was the States, I think maybe you'd be thinking a little bit more about the predominance of gunshot trauma versus knife trauma, and how that diagnostically obviously is completely sort of different ball game. But I thought Paris and London weren't too dissimilar. So I've said yes. Do the results of this study fit with other available evidence? As discussed, yes, it does. And the implications of this study for practice goes back to the beginning, really, the initial discussion, and that is within the UK, having sort of policies and protocols of where penetrating chest trauma goes. If despite being a stable patient, you go straight to an MTC based on the location of your injury, or if you do indeed go to a trauma unit based on your relative stability. And I think this study supports fairly strongly what we're currently doing in London, which is if you have a knife to the chest, you go to an MTC.
Great, Claire, thanks. That was great. Any thoughts or comments from others? Surprising, not surprising? Do you think they could have done anything differently? Was this a useful study at all? Does it change how you feel about anything?
I think it's positive in that it shows that probably, although it's kind of disheartening in terms of it's difficult to diagnose accurately these patients, it's quite encouraging in that we're doing the right thing with our trauma decision tool in London of just taking these all because they're so difficult to differentiate.
Yeah, it made me feel somewhat better, because there's definitely times where I've brought a patient in to an MTC and kind of thought, I really don't think that this is, I really have a very strong suspicion this is superficial, and you kind of feel a little bit bad that you're over triaging this patient, and then this sort of reassures me that that it's obviously not comforting that my clinical skills are not as good as one would hope potentially, but it comforts me that, yeah, I'm still doing the right thing by taking this patient to the MTC as opposed to just saying, oh, they can go to a TU, and that the threshold for that needs to be very, very high. Anything that would potentially maybe a game changer for this in the future that you can think of?
Ultrasound in the ambulance?
Ultrasound, yeah.
Yeah. Rory and Jason, are you guys doing pleural ultrasounds at all, or just echo at the moment?
Oh no, it's variable on confidence. I think with the ultrasound, some people do, and then some people sort of steer away from it. We're all sort of a mixed bag of how confident we are at the moment with our ultrasound, I think.
Matt, down in KSS?
I definitely use it. I use it more for echo rather than pleural, and it's raw in rather than raw out for pleural. But, you know, KSS did a paper talking about pre-hospital evaluation of pneumothoraces, even with an ultrasound, and we're shit at that anyway.
Oh, I don't know if I've seen that one. Okay. Good. The we talked about, 2 years ago or more, there was a whole thing about bringing in ultrasound here in a plan and all that stuff, and then Tom Evans left and other things have happened. But it's an interesting one for how, obviously if you introduce that modality, you'd want to redo this whole study and see if it changed anything. But
they also didn't use it in hospital here either. Well, they used echo, transthoracic echo, but they didn't.
Well, so when they said transthoracic, I think they were, if I remember reading the paper, they were using it for both lung and heart.
Oh, okay.
They were just calling it a TTE as opposed to there were a few parts in this paper where things were, I think, lost in translation from writing in a second language as we read through it.
I think talking to Robbie, I think Lindrum, he was quite keen. I'm sure he was saying that they're going to bring ultrasound back in again.
Yeah, we have funding for it from the that big grant from the government, and
the PRU have a nice little machine that can do like everything. Yeah, it's the one that it's good. I like it.
I think they're just looking at changing the ultrasounds at the moment, aren't they?
Yeah.
It's also the population is fairly narrow in that SAMU have to have been dispatched to the team. The patient can't self-present to this PACU. It's just, I think the population and the systems are too different, but like there's generalizable learning things that we can learn from that.
Yeah, I'm not sure enough about the SAMU system in terms of their dispatch criteria, who they go to, and
they're based in the hospital. They're like a merit team that go out.
Yep.
Oh, so it's more like CATS or something for peds, except
it is. Yeah,
obviously it's secondary transfers, but that kind of concept that you get dispatched and then you.
Yeah, although they're fairly active, they go to.
They do a lot of stuff. Yeah,
you spend basically based in the hospital. You spend most of your shift going out, from what I understand. Sorry, Rory, go ahead.
Oh, the concept of like a paramedic ambulance service doesn't really exist, does it? It's all fire. Fire the leads in France. So the kind of the only medical sort of intervention you get if you need anything is via one of these SAM teams, I believe, or just a fireman throwing you on an ambulance and driving you very fast to a hospital.
So the whole thing made me feel a little bit better, actually, in that if you look, they sort of define characteristics of wounds, and the long shot is when they define different characteristics of the wounds, the only thing that is a complete slam dunk that it's invasive is that it's a blowing wound, and I don't think that takes a genius to work out that if the wound has got like air coming out of it, it's probably breached the pleura. But beyond that, it made me feel a little bit better because I don't know if anyone else has had those night shifts. It's always West London, and you get like 3 in a row, like 3 in 3 hours. And it looks like someone's taken like the smallest Victorinox knife they could find, and they've just pricked people like they're a lamb having garlic cloves put in. And you sequentially bring these patients in with these little nicks. Bill's shaking his head. you bring these people in with these like little nicks, and once you get
and you have to like soup it up when you do your handover.
I know. And the trouble is that
you back from the precipice of death.
You still have to do the pre-alert call, right? You still have to turn up like central chest stabbing.
Yeah.
And once it gets to like number 3, like you're starting to look at the because especially Marys don't triage their trauma calls. You're starting to look at your anaesthetist with utter sympathy because you know full well you've dragged them from. It made me feel a little bit better about A being that person, and B it made me feel a little bit better that the number of patients that, I don't know, if they've had a head trauma, we've tubed them, they've had bilateral air entry, and then when you put them through the scanner, they do actually have small bilateral pneumothoraces. I couldn't tell. They didn't have any surgical emphysema. It makes me feel slightly better about the patients that have got a nick to their chest and you're trying to work out if they've got a hemopneumo or a tamponade, or it just turns out that statistically it's quite difficult to work it out, I guess.
Bill, Varsha, any thoughts from you?
Hi, sorry, I haven't got my video on. It's just that I'm post-night and I'm sitting in a very dark room, so which is why I don't have the video on. But no, I was just thinking about the very case that Claire was just describing about the nick to the wound. Obviously, I haven't got any experience of seeing these patients pre-hospitally, but I've seen them in trauma centers. And as Claire's just said, working at Mary's, we would all slightly roll our eyes when we heard this little nick to the chest that's come in. But then we'd have these very long discussions after the pre-hospital teams left to say, do we want to scan their chest or not? And invariably, we've always ended up scanning them simply because we don't actually know the length of the knife or the sort of, instrument used to make this wound happen. So invariably, they've ended up with scans and it's gone either way. Sometimes we've been very surprised with a very large pneumothorax or a pneumomediastinum or whatever. And sometimes it's just been absolutely fine. So I think, this is a fairly reassuring paper to have heard, actually. So it's interesting. Thank you.
Bill, were you or Rory or Jason, anybody around in the days of things like the bicycle spokes and stuff like that I used to hear about in London in terms of these small innocuous looking wounds being quite pictures? I haven't seen any of those in my few years that I've been here.
Knitting needles.
Knitting.
They still with a knitting needle. Cut the end off a knitting needle, put it into a pencil eraser and push it through that way. It's quite common around Hackney, Islington, Newham, Tower Hamlets. It was really common to see someone have a small puncture wound. It was actually quite deep, particularly in the back.
Sorry, I was just saying, we've had a couple of those and I've been really surprised because they've been, and the size of their pneumothorax, I would not have imagined. I would have almost been quite confident to have sent them home even without an X-ray. And again, I know that's misplaced confidence there, but there have been some fairly tiny wounds that have surprised me working in London. Yeah.
Yeah, I think it's nice that the days of trying to stick a pencil or a pen in the wound to see how far it tracks have gone. I haven't seen that in Kings for a while now.
In the Omerton, Joe.
yeah.
Okay. Anything else from anybody?
Just on the venous hemoglobin, how accurate is that to do on scene or quick?
Oh, this is my favorite med student question. So we used to always pimp med students and residents on rounds and say, if I drain a liter of blood from you right now, or drain half your blood volume and take your hemoglobin before and after, what will it be?
It's the same, isn't it?
Yeah, pretty much.
Or,
especially if you do it immediately, because you haven't had a chance for dilution. If you give them a couple liters of crystalloid and salty water to make them really sick, then it will drop. But yeah, so it was interesting that you picked up that they did that and that they had that, and I'm like, why? You're wasting your time.
You'd be better off actually just having a ped cap gas, and if you're going to get a drop from them, just doing a whole capillary gas, and then at least you'd get like a lactate and
That's what I was going to ask. I was going to ask, what if you were going to do one test to try and help, what would you do? But lactate, base excess, maybe. KSS did a paper on that. They were supposed to have a Rotem coming out for pre-hospital that they were studying at Mary's, but I never. They were going to be studying at Mary's, but I never haven't heard anything more about it recently.
The other thing of interest that I kind of spotted, and I'm post nights as well, so I'm probably just misreading it. But if you look at the table that's got the characteristics of patients with and without final diagnosis of invasive wound, that's effectively, if you look down at their clinical parameters, their odds, things like a pre-hospital systolic blood pressure was statistically significant in the difference between those with invasive wounds and superficial wounds, which in a cohort of 150, so I was quite surprised that you managed to get such a difference. But then when you actually look at the numbers, it's 110 systolic compared to 120 systolic, which was a bit like it's quite a narrow kind of gap. So I'm not sure how they've managed to get a significant difference in that. But
yeah, and it's also interesting that they that if you were to look at them, neither one of them would be alarming sort of systolics to you.
Yeah, exactly. Yeah.
So,
And I think you wouldn't notice it as if that was the only ob you had, you would pay more attention to it. But in a spectrum of observations that you get, you would never. I don't think you would ever go 110 systolic. That's really worrying.
Yeah, there's lots of interesting things in this paper if you dive into some of those tables and stuff. There's also some strange things. The one table that Claire had, which showed invasive versus non-invasive, that they actually had a number of unstable non-invasive wounds, which was slightly interesting. But so I was trying to curious what they were, but they may have been I think that's what you said. It was back a few slides. That one. Superficial wounds, and you look across to the far right side there, 6 unstable patients. It shows, I don't know, where are they, what are they unstable from? That's interesting. They say they didn't mention their cut off arm or their slashed junctional wound or something. All right, so there's nothing else. Thanks a lot, Claire.
Thanks, Claire.
And who's doing it? Claire, do you remember?
Next up, I think, is John.
Okay.
Yeah. I think we've just gone on in the order that we've arrived.
Okay. And Claire's going to give a sort of 5-minute update at CGD for those who couldn't make this. And we'll stick the recording up somewhere so that people can see it if they didn't come. We'll see how it goes. All right. Thanks, everybody.
Cheers.
Take care. Bye.
Thanks.
Have a good weekend.
You too. Bye.
Thanks.